Hello, I'm Dr. Pribil. I'm a board-certified neurosurgeon. I specialize in diseases of the neck, mid-back, as well as the low back. I'm here to help you understand the symptoms you may be having after an automobile or a trucking accident or after a spontaneous disc rupture. I focus on understanding the nature of your pain, and then I address it in the least invasive way that I can to help you. One thing I like to do for my patients, their legal representatives and insurance companies, is to give them a video interpretation reading of the spine MRI and denote the problems that exist and see if there's any surgical intervention that might be helpful to alleviate the discomfort. I do this because the average individual does not understand the reading of an MRI, and I think it's very important that they understand these significant findings, how it causes their pain, and how it contributes to their neurological findings. This is an MRI of the cervical spine of a 71-year-old gentleman that car pulled out in front of him and he rammed into it in a T-bone fashion at about 55 miles an hour plus. He experienced sudden acceleration, deceleration forces. His head bobbed forward and back, hit the headrest, and he experienced a neck injury. So what we have here is we have a preservation of the normal curvature. His 7 cervical vertebrae, 1, 2, 3, 4, 5, 6, 7, and this is a T1. So you can immediately see evidence of some disc herniations here at the 5, 6, and 6, 7 level. He's got little irregularities here at the 4, 5, and a little bit at the 3, 4, but this is the most pronounced, the 5, 6, and perhaps a little bit at the 6, 7. When we look at the axial images and bring them down to the 3, 4 level first, you will notice that he does have a very minimal type compression, but it's pretty good open nerve foramina here on the left. The one on the right is a little bit narrow. Maybe some headaches may come of that. Going down to the 4-5 level, the gentle disc herniation has a little more preponderance to the left side. Open space, the nerve foramina on the right. On the left, he has a little bit of a narrowing, as you can clearly see. Moving down to the 5-6 level, however, this is where the real problem starts. Is a severe narrowing on the right side at that C5-6 level, more so with a diffuse disc herniation that is compressing this anterior margin of the spinal cord, and it narrows the exiting nerve root. So I expect him to have symptoms in the C5-6 area, namely in the wrist turning, twisting, and in the numbness along the base of thumb and base of index finger and the first web space. Typically, they also have decreased vibratory appreciation in this area. The fact that he also has disc herniation extending to the left side would make me believe that he would have some symptoms also to the left side. At the 6-7 level, you can see here that there is clearly a disc herniation in the foramen and some evidence of perhaps either cystic, inflammatory changes or whatnot, but there's clearly a narrowing of this exiting nerve root on the left side, and you can see this disc herniation causing compression of these exiting nerve roots. There's maybe a little bit of a disc herniation alongside here, but most pronounced is this high signal, which is an indicator of a tear in the annulus and then disc herniation underneath that. So this individual, if he were to have symptoms that would be referable to the C5-6 level and to the C6-7 level, I would recommend a 2-level artificial disc replacement after all these places are cleaned out, after the disc is removed, and after these foraminal components of herniations are removed. Then I would place an artificial disc in at both levels. The typical routine reading of a radiology of this MRI would reveal that this is probably minor type of bulges instead of actual disc herniation. But when you really critically analyze this and magnify and look at the distances front to back that show whether there is a normal caliber to this spinal cord, typically what I do is I magnify it and I go to this tool I have here, which allows me to measure the distance front to back. And when I measure let's say at this level, which is behind the body of C5, I get a 6.24 millimeter front to back distance. When I go to the disc herniation at the 5-6 level and I measure again the distance front to back of the spinal cord at that level, I come up with about a 5.9, 5.1. So there's a whole millimeter worth of difference, which indicates that at the 5-6 disc herniation level, there is an indentation and pressure on the spinal cord. So imagine what happens to the nerve fibers that course through the spinal cord. And of course, you know that there's about 1 million nerve fibers running up and down. So this degree of difference in the pressure implies that the same number of fibers has to go through a narrower space, meaning they're crowded, they're crunched, and there's pressure on the nerves, there's pressure on the blood vessels, and it leads to certain physiological abnormalities that are expressed then as pain and as neurological weakness or numbness. So reading and analyzing the distances of the spinal cord when there are compressed areas is crucial to determining the clinical correlation to the radiographical findings. And again, if I look at this area here, we're back to about probably 6.3 front to back. So it opens up. So you can clearly appreciate the compression right through the area of the disc herniation. For those of patients who are out there who have been told that they need surgery and who have been contemplating surgery but are concerned, I can assure you that in the 37 years that I've done cervical surgeries and lumbar surgeries, I've perfected the techniques to really help patients, first with lumbar and cervical fusions many years ago, and more recently with the artificial disc replacement surgery in the neck, which is an extremely beneficial surgery for patients with neck pain, all in the outpatient setting. So we can do these surgeries now outside of the hospital in an ambulatory setting to help get you on your feet as soon as possible.